Health Policy by Professor Tammy.
Health Policy, Part 2. Development of Legislative Health Policy. Policy Cycle. Making health policy is a complex process. It involves both private and public sectors, including multiple levels of government. The formation and implementation of health policy occurs in a policy cycle comprising 5 components. 1. Issue raising. 2. Policy design. 3. Building of public support. 4. Legislative decision-making and building of policy support. 5. Policy implementation. These activities are shared by Congress and interest groups. Legislative process. A bill is introduced to the House of Representatives, that's the Congress. It is assigned to a committee by the Speaker. It is reassigned to a subcommittee. It is sent to agencies to hold hearings, markups, to get testimony and possible amendments. Committees and subcommittees may recommend, not recommend, or table the bill. The full House hears the bill. Remember, the full House, the House is Congress, House of Representatives, same. The full House hears the bill, at which point they may further amend it. If it is approved, they send it to the Senate. The Senate follows the same procedure, the same process as the House. However, if amendments are added in the Senate, it goes back to the House for approval. So it goes back to Congress, the House of Representatives. After the bill has passed in both the House and Senate in identical form, it is forwarded to the President for his signature or her signature. If the President signs the legislation, it becomes law. Once legislation is signed into law, it is forwarded to the appropriate agency for implementation. The new regulation is posted in the Federal Register. Hearings are held to see how the law would be implemented. The bureaucracy publishes, gathers comments, and rewrites regulations. The program goes to 50 states for enabling legislation if appropriate. Local interests begin a new political process to shape the final outcome. Critical policy issues: access to care, providers, public financing, access in the elderly, access in the minority, access in rural areas, access in low income, access and persons with AIDS, cost containment. Critical policy issues: quality of care, research and policy development. Government health policies are enacted to resolve or prevent deficiencies in healthcare delivery. Healthcare has been focusing on access to care, cost of care, and quality of care. In access of care, expanding insurance coverage and outreaching to rural areas. In cost of care, PPS, Preferred Provider Organization, and RBRVS, Resource-Based Relative Value Scale. In quality of care, you have AHRQ, Agency for Healthcare Research and Quality and Clinical Practice Guidelines, as well as CMS, Centers for Medicare and Medicaid Innovations and Accountable Care Organization. Policies on access are aimed primarily at providers and financing mechanisms, with the purpose of expanding care to the most needy and underserved populations such as the elderly, minorities, rural residents, those with low incomes, and persons with AIDS. Providers. Policy helps to ensure that there are enough providers and that their geographic distribution is desirable. The supply of physicians is a policy issue that could influence people entering the medical profession. Entrants to medical professions are influenced by government assistance and grants. Policies have expanded to include the National Health Service Corps, legislation supporting rural health clinics to expand access, student assistance programs to emergency medical services, establishment of community health centers in inner cities and rural areas like rural towns. Public financing. Many see national health care as the best way to ensure access. The United States, however, focused on certain groups such as Medicare and Medicaid, established the precedent that government should facilitate access to health care among those unable to secure it for themselves, access and the elderly. Two main concerns about the Medicare policy: spending must be restrained to keep the program viable. The program must be made comprehensive by adding services not currently covered or covered inadequately, such as nursing home coverage. Access and minorities. Minorities are more likely than whites to face health access problems. Low income, minority status, cultural habits cause access problems. Policy should encourage sensitivity programs to the special needs of minorities and delivery of services to areas populated by minorities. Access in rural areas. In rural communities, making medical care available to residents is difficult because most healthcare organizations are established in more urban areas. The National Health Service Corps helps address personnel shortages in rural areas, but only for a limited time. Programs to create incentives for permanent practices in rural areas are needed. Access and low income. Low-income mothers and their children have problems accessing the healthcare system. They lack insurance and generally live in the medically underserved area. They are also less likely to receive prenatal care, that is the care when you're pregnant. Chip, also known as Chip, Children's Health Insurance Program. Federal funds with some state flexibility is there. Target health care coverage for children. So, if there's a family without health insurance, the kids can get health insurance, but the parents cannot get health insurance through CHIP because CHIP is only for children. Access and person with AIDS. Person with AIDS and those who have HIV have problems obtaining health care. AIDS patients have difficulty getting insurance. Their disease process leads to catastrophic expenses. That means beaucoup, lots and lots of money, very expensive. Financial access can be a barrier. AIDS is a challenge to policymakers committed to universal access. Cost containment. The strength of the U.S. healthcare system contributes to its weaknesses. The United States have the latest technology and well-trained specialists. This leads to the most expensive means of providing health care in the world. Two major policy initiatives enacted by the federal government to contain costs have targeted hospitals and PPS, preferred provider organizations, and physician services with RBRVS, Resource-Based Relative Value Scale. The National Health Planning and Resources Development Act of 1974 became law in 1975. This act marked the transition from improvement of access to cost containment as the principal theme in federal health policy. Health planning through a certification of need review was a policy tool to contain costs. Quality of care. Along with access and cost, quality of care is the third main concern of healthcare policy. The Healthcare Quality Act of 1986, legislation that mandated the collection of national data on legal actions against healthcare providers. This information allows people to know action brought against physicians in other states. Agency for Healthcare Research and Quality, AHRQ, and goal is to conduct and support research on outcomes, effectiveness, and appropriateness of healthcare services and procedures. AHRQ, Agency for Healthcare Research and Quality, funds patient outcomes research teams, PORTS, that focus on certain medical conditions and that are part of the Medical Treatment Effectiveness Program, which has 4 elements. 1. Medical treatment effectiveness research. 2. Development of databases for research. 3. Development of clinical guidelines. 4. Dissemination of research findings and clinical guidelines. Research and policy development. You need to document, because if you don't document, it's assumed that it did not happen. Analysis, program evaluation, and outcomes research. Prescription, a course of action that has a desirable consequence. Health policy after the Affordable Care Act. Remaining challenges are: option to opt out of expanding Medicaid coverage left some residents in a coverage gap, earning too much and too little at the same time. Undocumented immigrants do not qualify for Medicaid and cannot purchase marketplace coverage. International health policy comparisons. The 2014 Commonwealth Fund International Health Policy Survey sought to categorize the experience of patients in 11 countries: the United States, United Kingdom, Australia, Canada, France, Sweden, Germany, the Netherlands, New Zealand, Norway, and Switzerland. All have universal coverage structure except the United States. All except Germany and the United States enforce gatekeeping methods for tertiary care. The United Kingdom and the Netherlands have the most comprehensive programs, while the other countries use method of cost sharing or benefit gaps in coverage. Practices in Canada and the United States are least likely to have electronic medical records. The United States spends twice as much in per capita on health expenses compared to the average in the next highest cost country. Only the United States has an uninsured rate above 2%, estimated to be 12% uninsured in 2014. Conclusion: health policies are developed to serve the public's interests. National health care is supported, but the idea of federal government running the system is not preferred. For now, maybe. The challenge is finding a balance between government provisions and control, and the market to improve coverage and affordability.
See you soon, and remember to read the book.